Welcome to Part 5 of Changes Now, in which we address financing and payment for dental care in the U.S. In this presentation, we'll first take a look at coverage, its sources and how dentists get paid for each of those sources, as well as trends in who is paying for dental care. Take a look at the issue of affordability, which drives Part 3, policy, to address financial barriers to care, both in terms of the historical trajectory of efforts to expand health coverage in the U.S. and the resultant hodgepodge of coverage that we now have. And then taking a look more closely at alternative payment mechanisms that support value-based care, what the triple aim is and how it is driving alternatives to payment, how that payment is already underway in medicine, how it is beginning in dentistry, how organized dentistry has responded, and some examples that are impacting pediatric dentistry at this time. A 2020 report from the CDC's Office of Disease Prevention and Health Promotion in support of the Healthy People Initiative issued this call for addressing barriers to access to care. In its report, The Role of Law and Policy in Increasing the Use of Oral Health Systems and Services, they note that, quote, financing and affordability are critical aspects of determining when and whether individuals use oral health care. Oral health care has traditionally been funded by three sources, and those sources are government, through public insurance as well as direct care programs, employers through employer-sponsored insurance, and individuals through payment out of pocket. Let's look first at government as a sponsor of dental payments. As we can see from this slide, there are two major buckets, two major streams of payment that come from government ultimately to dentists to provide care. One is through insurance programs, and the other is through direct delivery programs. On the insurance side, most of them are managed by the CMS, the Federal Centers for Medicare and Medicaid Services in the Department of Health and Human Services. These programs are primarily intended to fund low-income and socially disadvantaged populations. Regarding adults, there's Medicare for seniors, which at this time in 2022 does not cover dental services, and Medicaid for the poor and disabled. Now, Medicaid officially leaves it up to each state as an option to determine whether or not they provide dental services in their package of covered benefits. However, Medicaid has a particular provision for children that has been around since 1967 called EPSDT. The EPSDT benefit, which stands for Early and Periodic Screening, Diagnostic, and Treatment Services, requires that states identify children eligible for Medicaid early, provide early examinations of those children, periodic services, including dental services, that a child be screened for any health problem, diagnosed for that problem, and then treated for that problem. So under EPSDT, as a sort of backdoor to dental coverage in Medicaid, all children anywhere in the United States are provided with comprehensive dental services. Similarly, the Children's Health Insurance Program provides comprehensive dental services for children whose families are in the next tier up of income. So they're not families as poor as to qualify for Medicaid, but qualify instead as working poor for the Children's Health Insurance Program. There is another smaller insurance program managed by the Department of Defense called TRICARE, which provides dental benefits along with medical benefits for military dependents, that is the children and spouses of active duty military. On the direct delivery side, the largest component are the federally qualified health centers. These are funded directly from the federal government to the locale where the federally qualified health center operates, directly to the FQHC, and requires that every FQHC include at least preventive, if not totally comprehensive, dental benefits to all comers. Then there are a series of direct support programs for specific populations, active duty military, veterans through the VA, prisoners through the Federal Bureau of Prisons, people in the Native Americans through the Indian Health Service, people affected by the HIV/AIDS epidemic, and of course Head Start that has a broad set of requirements that include dental supervision. Many of these programs are delivered by active duty members of the National Health Service Corps. Others are employed directly, for example, by the military, the VA, or the Bureau of Prisons, or the Indian Health Service. The way dentists get paid under these two streams are different. On the insurance programs, dentists are paid fee for service by some vendor working for the state that covers Medicaid and CHIP, or directly, like any other insurance company, through TRICARE, while on the delivery program side, the dentists are generally salaried. On the employer side, there are at least 4 ways that employers arrange for payment for their beneficiaries, for their employees, to receive dental services. The most common are the indemnity, the traditional fee-for-service, or sometimes fixed fee plans. But also there are capitation plans, there are direct reimbursement plans, and there are discount or referral plans. Within the indemnity plans, there are a number of considerations for the patients, the providers, and the employers themselves. For the patients, the considerations are that there are often very tight annual and lifetime caps. There's a lot of copay and deductible that leads to out-of-pocket expenses, and there may be procedural limits or required substitutions. That is, that payment is for a substituted procedure. Under the provider considerations, the payments are set around usual and customary and reasonable charges, but they may be negotiated, and there are contracts that make some people preferred providers under a variety of circumstances. For the employers, the benefit is that it's comprehensive. It may or may not provide dependent coverage. It may or may not require quality or performance standards, and it may or may not require that the vendor provide for network adequacy. So there's a whole complexity that's involved in all of these types of payments, but they are determined by the employers as purchasers of care. Looking now at how dentists get paid, under indemnity programs, there are basically 2 categories. Either the dentist participates under contract and is therefore an in-network dentist, or is non-participating and out-of-network dentist. And either way, the payment is ultimately fee for service. In the in-network, there is a negotiated payment that the dentist agrees to accept, while that is not the case in the out-of-network, in which the patient pays the balance. Under capitation programs, the dentist is paid a fixed monthly payment, a fixed monthly allotment to care for a defined group of patients, a specific number of patients. The capitation plan may require dentists to report on utilization, or may not, and may provide bonuses based on performance. Under the direct reimbursement plans, the dentist bills the patient then takes evidence of a paid bill to the employer, and the employer pays the patient, the employee. Under the discount plans, the dentist again bills the patient directly, but does so under a predetermined discounted fee, and the patient pays the dentist. Looking to the third source of payment after government and employer-sponsored plans, we see that individuals pay directly for dental care. Now, until 2010, people who did not have insurance from any other source were simply uninsured, and they paid out of pocket. There was a small individual market, but it was very high cost, and it was very highly screened, and it had very limited benefits. So it was not a very popular option. Well, in 2010, the Affordable Care Act, also known as Obamacare, established a private market, a publicly funded private market for health insurance for people who did not have sources of care through any other avenue. And under the Affordable Care Act, there is a requirement that children, but only children, be covered with comprehensive dental services. Adults who obtain their coverage through the Affordable Care Act may find a secondary market linked to the Affordable Care market in which they can purchase dental care. That's very much like the old individual market. So until 2010, people without employer or government coverage had to pay exclusively out of pocket. Since that time, it is possible for people to purchase insurance on the private market funded with governmental support. Readily apparent from this bar graph is that government is a very modest funder of dental services in the United States. Now, a disproportionately high portion of that 10.7% is paid for pediatric dental care because Medicaid, CHIP, and the Affordable Care Act all include dental services for children. Employer-sponsored insurance, on the other hand, constitutes about 50% of dental expenditures on dental payments in the United States. A surprisingly high portion, even with all those people having either governmental coverage or employer-sponsored insurance, a surprisingly high portion of U.S. dental expenditures are still paid out of pocket, more than a third. And that is because many of the employer-sponsored plans have very strict limitations on the annual and lifetime caps, as well as requirements to pay for copays and other attendant expenses for non-covered services. The funding picture for dental care has changed dramatically over the last 60 years. As you can see from this bar graph, out-of-pocket constituted the almost exclusive source of payment for dental care in the 1960s. That portion has declined steadily to a bit over a third, while the advent of private insurance and the slow increment in government insurance, primarily for children, has ticked up and replaced a lot of that out-of-pocket expenditure. Despite all of these sources of dental payment through employers and government programs, we find that dental care still is the least affordable of healthcare services. This landmark article by Marko Vucisic from the American Dental Association Health Policy Institute entitled "Dental Care Presents the Highest Level of Financial Barriers Compared to All Other Types of Healthcare Services." The title says it all. If we take a look more closely at the graph on the right, you see that the dark bar on the left in each set is dental care unaffordability. And dental care is the least affordable healthcare service compared to medical, prescription eyeglass, and mental health care across all categories of individuals. Those who have private health insurance, those who have private health insurance with and without dental, those on Medicaid, and those with no insurance at all. In this graphic, we take a look at unaffordability of care as a function of age. And we see that even for children, ages 2 to 18, those in poverty have the least affordability of care, perhaps because some of those people are not enrolled in Medicaid, or don't know they're eligible for Medicaid, or are in fact ineligible for Medicaid. As children age out of the Medicaid EPSDT benefit, they fall into this age group of 19 to 64, and because it's up to each state to determine whether they provide dental coverage for adults under Medicaid and the extent to which they provide dental benefits in their adult Medicaid program, we see that unaffordability of care increases again for the working age group. And then it diminishes for people 65 and older, perhaps because they have less demand for dental services and have not reported as much unaffordability in this National Health Interview Survey. To recap the issue of unaffordability of dental care, something that is driving public policy as people find that dental services are too expensive for them, we take a look at the ADA Health Policy Institute findings across multiple years. Back in 2016, they reported that irrespective of age or income or type of insurance, more people face financial barriers for dental care than any other type of care. That's that article that we just took a look at. Again, in 2016, dental care presents the highest level of financial barrier. 2018, cost is by far the top reason adults avoid going to the dentist. 2019, main barrier is affordability. Again, people are not receiving what they perceive to be their needed dental care. 2020, only 36% of working age adults had a dental visit. That's only a little more than a third of adults had a dental visit at all. However, because of Medicaid, CHIP, and the ACA, as well as dependent coverage for employer-sponsored insurance, children's utilization has fared much better and has actually increased over those same years. To put U.S. healthcare financing policy in perspective, we start with this slide that shows that the United States is truly an outlier amongst advanced countries in not providing universal health coverage with or without dental services to its population. It's not for lack of trying by every president since FDR to enhance health coverage for the entire population in the U.S. In fact, every president since FDR has attempted to make some modification to expand coverage or to tweak coverage or to enhance coverage in some way. The really big advances, incremental though they may be, happened under Lyndon Johnson, Bill Clinton, and Barack Obama. Under the Great Society programs in the 60s, Johnson administration expanded coverage for the elderly, for the older adults, through Medicare, through poor and disabled people of all ages through Medicaid, and then that was in 1965, and then just 2 years later with EPSDT, the children's benefit was tweaked to ultimately include dental services. CHIP included dental services, but only as a state option. A number of years later, under the Obama administration, the CHIP Reauthorization Act expanded the coverage to specifically state that dental coverage for children would be covered, and the subsequent Obamacare, the Affordable Care Act, included a requirement for dental coverage. So as a result, we now have a hodgepodge of services that we'll take a look at in the next slide. This slide recaps the advances, the incremental advances in dental coverage, with Medicaid for the poor in 1965 leaving dental optional, but then in 1967 it becoming mandatory. 1997 with CHIP, again optional, becoming mandatory in 2009, and then the Affordable Care Act. So overall, children are well served by public insurance. What kind of health coverage you have as a U.S. resident or U.S. citizen depends upon your age and your level of income. If we take a look at this chart, and please do take a close look at this chart, you'll see that for children, that is up to age 21, those who live in families in poverty with incomes up to 100% of the federal poverty level, a level that is adjusted annually, we see that the children are covered by Medicaid with its mandatory EPSDT benefit. For the next income level up, children whose families are considered to be in the working poor, that's 100 to 200% of poverty, 2 times the poverty level, is CHIP with its mandatory dental benefit. And then beyond that, parents can secure coverage through the Affordable Care Act, through that private market, or through the benefit secured through their employer-sponsored insurance, ESI. So overall, children have very good dental coverage. The poorest with Medicaid, the next level up with CHIP, and beyond that with ACA or ESI. There are some hitches in this. There is what's known as the family gap that leaves some dependents without dental coverage, even if their parents have employer-sponsored insurance. But in general, children are well covered. As you take a closer look at adults and seniors, you see that dental benefits really drop out. They become state option in Medicaid. They become optional with some Medicare Advantage plans. That's the private market that is embedded within Medicare. But in general, adults, particularly as they age, lose dental benefits. The remainder of this presentation is about value-based care and alternative payment mechanisms as we look toward the future to see where payment and funding may go, especially during careers that will be rolling out over the next 20 to 30 years. The concept of value-based care is that payment should be made for health outcomes, and that payment should be made to reward high-quality care that is also less expensive. Less expensive quality care can be achieved by going upstream to prevention and by addressing the patient holistically, considering the social determinants, environmental and behavioral determinants, as well as the clinical determinants of health. And that may be particularly true of oral health care for children, where carries prevention and carries suppression, carries management, engaging families to adopt and maintain positive health behaviors can both increase quality and reduce cost. Value-based care is supported in turn by alternative payment mechanisms, and those payment mechanisms may provide positive incentives, for example, bonuses, or they may institute negative incentives, that is, financial penalties for not achieving care targets. The foundational document that outlines alternative payment mechanisms comes from the Healthcare Payment Learning and Action Network, and it's the white paper, the monograph shown on the left, along with its website, the link to the web. I strongly encourage those who are interested in learning more about alternative payments to look carefully at this document. We will take a more cursory look at these 4 levels that are represented in the figure on the right. These are the 4 categories advancing from category 1, where we are now, which is fee-for-service unrelated to quality or value, up to category 4, a complete population-based payment mechanism. Category 1 is not really an alternative at all, because it is what we have now. Fee-for-service unrelated, as the triple aim calls for, to either cost or quality. Category 2 is where much of the activity is ongoing now, both in medicine and, as you'll see later in this presentation, in dentistry as well. So category 2 still sticks to fee-for-service, but it ties payment to some other measure. At the first level, it simply ties payment to the provider accessing and instituting an electronic health record that is competent at reporting services and reporting outcomes. Those are early in dentistry. They're much more advanced in medicine, but there's payment to not only provide the service, but to be able to report the service. The second level, B, under category 2, pays the provider, pays the dentist in our case, to report on care. Or it could use a negative incentive. It could punish the provider for failing to report. And it could do that by withholding part of the fee-for-service payment. It could provide a positive incentive by paying a bonus. And then at level C, it takes a look at the services provided against measures that are believed to describe quality of care. And for that, it's payment for performance. The payer not only pays fee for service, but pays a bonus based on performance. As we move to level 3, we see it's still related to fee for service, but now considerably more sophisticated. Now we have the expectation that higher quality care at lower cost will result in savings. And the subcategories A and B deal with how those savings are administered. Under category A, there are bonuses paid to providers whose care results in higher quality at lower cost. So those savings then go back to the provider, at least in part. Whereas in level B, penalties are instituted. As we move to category 4, things change entirely. Now we're talking about global payment or population-based payment. Under global or population-based payment, a defined group of people, say all the employees of a particular employer or all the people on a particular government program in a state, all the people covered are paid by a single lump sum to a health system. Now, currently, those health systems do not tend to include dental care as well. These are the accountable care organizations earlier discussed. But increasingly, accountable care organizations are incorporating dental services. And these organizations would then receive a global payment, a single payment, and it would be up to the organization to determine how they would distribute that payment across their providers. If you take a moment to carefully review the content of this slide, what you'll see is that these sequential steps from the straight fee-for-service unrelated to quality and outcomes that we have now to global population-based care are incremental methods of getting to the triple aim. To give you a little insight into how rapidly the switch from fee-for-service to alternative payment mechanisms is underway, there are multiple congresses, national meetings, publications, information, particularly on the medical side, not as much on the dental side, that highlight the advantages of shifting from paying for services, that is volume-based care, to paying for outcomes. Take a good look at this list. On the medical side, the largest payer for healthcare is, in fact, government. That's very different than on the dental side, where, as you saw previously, only a small percentage, about 11%, of dental expenditures are paid for by government. On the medical side, therefore, government is much more an active player in moving toward value-based care. And this slide details a number of the programs currently underway by the federal government to move from volume to value. In sharp contrast, on the dental side, there's much less going on with alternative payment mechanisms at this time, although we will take a look at what is going on. But we can expect much more interest amongst employers pushing on their insurer vendors to move toward value-based payments in dentistry. To understand what's going on with value-based care in dentistry, let's take a look at a couple of documents. One is a 2020 document from CareQuest, and another is a 2021 document from the Center for Healthcare Strategies. The first one states that there's a need for provider awareness about APMs, and that the COVID-19 pandemic has created opportunities to advance alternative payment mechanisms. And here's some key findings from their report. Just over half of dentists had never heard of APMs, although APMs are increasingly being used in Medicare and in Medicaid and in federally qualified health centers. So there's some activity bubbling up, and we need to become increasingly aware of how this system works. Here are 4 take-homes from the CareQuest document suggesting that these changes are likely to be forthcoming within dentistry. First is ever increased attention to prevention rather than repair. That's where the value comes from and where the quality and the savings come from. A shift of dentistry into a more integrated position, not only medical dental integration, which is active on its own right, but integration of dentistry into larger and larger vertically integrated healthcare systems. An expansion of dental electronic health records so that they can be used for reporting and thereby have dentists paid for reporting, as we saw under the HCP-LAN model. And then a move from one-size-fits-all care, that is every child every 6 months for a checkup, to a very tailored, individualized care with the best possible allocation of resources to need. The 2021 document from the Center for Healthcare Strategies takes a different look at the oral health inclusion of value-based payments, alternative payments, and value-based care in dentistry. This brief, as it states here, summarizes what the different models are. That's the 1 through 4 that we looked at earlier. Examines challenges and opportunities to integrate value-based payment in the oral health environment, and provides considerations for how to expand value-based payment in dentistry. This is the kind of document that employers use to learn more about the opportunities they may have to press their insurers in moving from volume to value. This slide provides considerably more detail from the Center for Healthcare Strategies report to look at each of the levels of those HCP-LAN categories, 1 through 4, and how they might be implemented in dentistry. For those of you who are particularly interested in seeing how value-based care and alternative payment mechanisms may evolve in dentistry, you may find the report and these key findings of particular interest. The American Academy of Pediatric Dentistry's Pediatric Oral Health Research and Policy Center has taken a close look at value-based care, value-based payments, alternative payment mechanisms to see how they might play out in dentistry. And it starts with a very strong distinction between medicine and dentistry, stating that you can't simply take changes that are underway in medicine and tag them along onto dental care, because there are some significant differences in the organization and delivery and workforce of dentistry compared to medicine. Nonetheless, the brief does note that these changes are underway and that there's interest in value-based care in dentistry. It defends pediatric dentistry as it now exists, stating that quality care is being provided, and it does detail the challenges involved in moving toward value-based care in dentistry, providing 15 specific recommendations for how to engineer a shift from volume-based care to value-based care in dentistry. This slide highlights some of the differences between medicine and dentistry that make it challenging or require a significant modification of value-based care and alternative payment mechanisms if they're to be applied in pediatric dentistry. For example, our electronic health records don't provide the level of information typically needed to manage a value-based care system, in that we don't use diagnostic codes, that we don't have the more sophisticated electronic health records that are now present in medicine. It's also difficult to identify what quality care is in dentistry and to sort out the variability within dental care to determine what the best practices are. The Academy has gone a long way in developing best practice models to help reduce that variability. There's also questions about how to integrate medical and dental care systems and the ultimate need to address oral health disparities amongst children. Listed at the bottom of this slide are the 15 recommendations made by the Academy as pediatric dentistry considers the impact of value-based care on its practice. The federal government's IAP, or the Innovation Accelerator Program, has sought to assist states as they consider how to move from volume-based care to value-based care using alternative payment mechanisms and reorganizing the care delivery models. The 2018 report featured here details a number of those early efforts to move from volume to value in dentistry, particularly in pediatric dentistry. Consistent with value-based care, a number of efforts in pediatric dentistry have sought to enhance dental utilization, enhance parent engagement, and enhance preventive services over reparative services, while at the same time reducing the incidence of caries, stopping caries progression, and reducing the need for reparative procedures. This outtake from the IAP document just shown shows that there are 4 major areas of endeavor that are leading to value-based care in pediatric dentistry. The first is attention to early childhood caries, because if we can stop caries from its initiation early in childhood and suppress its succession over time, then there can be lower cost, better health outcomes. A second is outreach and service coordination. This relates very much to the social determinants of health, utilizing a variety of resources in communities to identify children at particular risk for caries at all child ages and get them into care through service coordination. A third, which the Academy actively promotes, is evidence-based practice, for example, through the care paths that are integral to AAPD's recommendations. And the fourth is interprofessional care, engaging primarily the medical system to identify children early who are at risk for early childhood oral health problems and move them into the dental care system. Also from the same IAP report, you see here on the left a number of efforts underway in various states that align with the various categories of the HCP-LAN model. So you can take a look and see that Texas, for example, has a Category 2 fee-for-service linked to quality. There's one in Pennsylvania that links APMs to Category 3, and a population-based effort in Oregon. On the right-hand side of the slide, you see that there are a number of recommendations from key informants about how to move dentistry, particularly pediatric dentistry, to value-based care. They include identifying, selecting, and utilizing quality measures, focusing on patient-centeredness and patient satisfaction as an outcome, utilizing best practices, and of course, improving data systems, our electronic health records, to reduce reporting burden, but also facilitate this kind of care. The other two suggestions made by the key informants are more about how to administer a value-based care program than they are about the things that need to happen in the dental office. They are to properly attribute patients to specific providers so that providers only get credit or negative incentives for their own patients and not somebody else's patients. And the other is to develop standard, validated risk adjustment methodologies so that if one group of dentists has a higher risk population than another, they're not financially penalized. These next three slides are provided with credit to Dr. Alex Sheen at NYU, who has recently compiled, that is in 2022, compiled value-based care programs underway in pediatric dentistry, especially those sponsored by the federal government. And what he has found is that there have been a series of drivers to encourage states to adopt value-based care in dentistry by the federal government. The various programs are 4 Healthcare Innovation Awards in South Dakota, New York, and Michigan, State Innovation Models in Oregon, Minnesota, and Ohio, Innovation Accelerator Program, that's that IAP that you saw earlier, in Michigan, New Hampshire, and DC, and the CHIPRA Quality Demonstration Programs. We're going to take a closer look at these next. Here are some of the approaches that these various states have taken as they think about moving from, or take those first steps in moving pediatric dentistry from volume to value. They include engagement of non-traditional providers, lowering costs, for example, by utilizing dental therapists to provide services that had previously been limited to only pediatric dentists. Non-traditional settings, alternative payment models, new payment codes, collaboration with a variety of partners in the healthcare system, medical dental integration, and development of oral health outcome measures. Dr. Sheen has taken a deep dive into each of the 12 programs previously listed and has conducted interviews, finding that amongst the 12 state endeavors underway through these 4 CMS endeavors, all dental value-based programs target children specifically, so they're of direct interest to pediatric dentistry. All of them involve some kind of incentive around reporting. All of them involve some kind of quality process measures. All but one involves a change in how dentists are paid, and all but 2 provide for new billing codes. So there's a great deal of activity underway, although it's nascent and it's early. It is creating the conditions under which states can begin to move their programs from volume to value. We will now conclude by taking a look at 2 states that are leading reforms in pediatric dentistry. We'll take a look at Michigan and Oregon. Michigan, according to this National Association for State Health Policy report in 2021, is utilizing almost all of the approaches that have been earlier discussed in this presentation, linking dentistry with medicine through medical dental integration for early assessment and prevention, supporting the use of support professionals like dietitians and social workers and health educators and community health workers, requiring dentists to begin reporting on social determinants, utilizing non-traditional service sites and providers like dental therapists, instituting new billing codes and an alternative payment mechanism, incentivizing care coordination for social services to address social determinants of health, enhancing health information technology, requiring enhanced reporting, and utilizing quality assurance and quality improvement requirements. So these are all the components that go into the shift from volume to value and are underway in pediatric dentistry reform in Michigan. Oregon similarly has used many of these same approaches, except they've gone all the way to category 4 in the HCPLAN rubric to global payment, with each county receiving a global payment to provide medical, dental, and behavioral health services to enrollees in Medicaid in that county. They've used financial incentives and bonuses. They promote medical dental integration. They encourage coalition building to enhance wraparound services for children. They are supportive of engaging federally qualified health centers in value-based care, and they've developed a strategic plan for oral health. In this final slide, we take a look at the various ways that the triple aim, better health outcomes at lower cost with greater patient satisfaction, can be achieved in pediatric dentistry. They relate very strongly to many efforts underway by the American Academy of Pediatric Dentistry. They include following AAPD's guidelines on prevention and caries management, ensuring that all children have a dental home so there's a responsible place for them to receive their care, enhancing electronic health records so that they can be used to better report on both the quantity and quality of care. Begin expanding the engagement of support professionals like community health workers and the ADA's Community Dental Health Coordinator. Delegate as much as possible services that the pediatric dentist doesn't need to do in order to lower cost, enhance efficiency. Aggregate practices to secure economies of scale, and prioritize the highest risk children so that the available resources are best utilized across the population of children. There are certainly many other ideas to be developed and to be forthcoming, but clearly there is a shift underway from volume to value, from fee-for-service all the way over toward ultimately global payment, and pediatric dentistry will likely become involved ever more in these changes as they evolve.